Good morning, everybody, and welcome to our complex nutrition webinar. My name is Farheen Akhtar. I'm one of the facilitators with the Greater Manchester Neuro and Stroke Delivery Network. The webinar today is a case study on the management of risk feeding in the community and will be delivered by Rebecca Howarth. Similar to previous events, we'll be doing a live Q&A session where you can pose questions to Rebecca at the end of the webinar. For any recordings and certificates, please do email Lisa. We do ask that you evaluate our webinar towards the end of this session, and please do leave us your feedback on any future events or any topics that you would like us to cover. Please do tweet us as well at GMNISDN. For any future events, please do see our website, and I will pop a little link to our website in the comments box for you. Our future events include obviously our annual stroke conference and our managing challenging behaviour, amongst others. And for any further details, please do contact Lisa Chadwick. Thank you for joining us today, and without further ado, I will hand you over to Rebecca, who's kindly agreed to do the webinar session for us. Thank you.
Good morning and welcome to our webinar. This webinar is brought to you in association with the Greater Manchester Neuro Rehabilitation and Integrated Stroke Delivery Network. My name is Rebecca Howarth, and I'm currently a specialist speech and language therapist working within Trafford Community Neuro Rehabilitation Team. I hope that there's lots of other speech therapists out there listening today who are also part of MDTs and that will find this webinar useful. In a previous life, I have worked for many number of years in acute settings, so I hope that my new experiences now working in a community setting are useful, and it's certainly thrown up some interesting quandaries and questions for me. I put my email address on there, so anybody wanting to email me afterwards, then that's absolutely fine. I'll get back to people's queries, comments or feedback. Thank you very much. I've put the aims here now on the next slide. I won't go through them because they were available when you were booking and deciding on attending this webinar, but really there was a lot of information and a lot of aims to get through today. I hope that I go some way into at least starting discussions. I'm not at all suggesting that I have the answers to all these difficulties, but hopefully we'll start some interesting discussions and help people in that way. First things first, I think it's useful actually to look at the terminology that we're using. Obviously, the title of this webinar is Risk Feeding, but actually we should be looking towards standardizing terminology. And I've just referenced here the recent guidance document from our Royal College of Speech and Language Therapists. And I think the consensus now is that we should try and use the term eating and drinking with acknowledged risks, which is a little bit wordy, but I certainly think that probably is more of a consensus statement that we should all be trying to use. I put in there the link towards the guidance document. I'm not going to go through it in any detail today. It's there for people to read through themselves. It's a really useful document as a framework. I've also put here just a picture of some of the leaflets that Lewisham and Greenwich department have done, because they've done a lot of work around procedure and leaflets around the area of risk feeding. They are all available on the Royal College of Speech and Language Therapists website, and I certainly would encourage people to look at them. Also available within the bundle that Lewisham and Greenwich have done is this document here, which is risk feeding guidelines, which is an example or a framework or template of a Misfeeding guideline document that you may go through with a patient themselves or with their carer who is deemed to have capacity. And it'd be interesting to know at the end of the discussion whether community therapists find these documents appropriate to use, easy to use, whether they've had any feedback from carers and from patients when they've been using these documentations in community. But these are currently available as well via our Royal College website. Also available through specific charities. This one is through Marie Curie. There is a document for information for family and friends, looking more specifically towards patients who have dementia and the end of their life. As you can see from the contents page, it does cover a lot of areas in this leaflet. So again, it's something I'd be interested to hear in the discussion if people have used this within other conditions other than dementia and how useful that has been and whether that's caused any difficulties when using that with a non-dementia patient caseload. Achieving with our patients, but they are only guidance. There's no specific procedure or protocol. So I think probably what we need to take from this is that there are still very much decisions that are going to be made on a patient by patient basis. I have just put in here for the non-speech and language therapists, if there are any of you that listen to this webinar, the IDSI framework reference. I'm going to, during some of the case studies, reference consistency levels for both drinks and food. So just to point people towards the IDSI framework so that you can fully benefit from the case discussions. So I put some key time points for my first case. So this case is an 86-year-old patient whose primary diagnosis is Parkinson's disease, but has subsequently and recently developed a significant dementia as part of that. The patient was first known to speech and language therapy in March 2019, and at that between 2019 and 2021, we can see the patient was stable because they were having unmodified liquids and unmodified solids. However, by April 2021, there was some texture modification around solids. So our solids had gone to a IDSI-4, which is a puree. So we are now moving to a stage where there are some eating and drinking difficulties. By June 2021, the patient had been recommended an IDSI-1 fluids, but had actually been moved up to an IDSI-6 on solids. I think this was more of a patient preference. However, although they were recommended IDSI-1, which does involve potentially the use of thickener, the patient didn't tolerate addition of thickener, and the husband had informed the speech and language therapy team that he had discontinued the use of thickener. Next key point is Christmas Day. Unfortunately, on 2021, the patient suffered a partial airway occlusion on what I think from discussion was a level 6 solid. She was cyanotic and the husband called paramedics, and thankfully her airway was cleared at that point and she was taken to hospital for chest x-rays but was discharged home fairly quickly the following day. Obviously, as a result of this, the GP got notification of this A&E attendance and the fact that there was an airway occlusion and there's now a query of an aspiration pneumonia. So the GP requested an urgent updated speech and language therapy swallowing assessment. I completed that assessment in February 2022, so that was my community domiciliary speech therapy assessment for this patient. So with our clinical observations in mind and with our scenarios from our guidance document, then we do need to think about how we're going to manage this patient's feeding, given all that information. We want to put in place immediate strategies to limit as much as possible the risk of airway occlusion. And I think that's something, if you feel that is a definite consideration, I think that should be done as a matter of urgency. So we may now be at the point at which we are going to have the discussion with a family member regarding the outcome of our assessment. And whilst in our mind we may have our own professional opinion about what we feel is the best pathway of care for this patient to go down, I think you need to start discussion about talking about all the options and try not to bring your personal opinion as to what you think is most appropriate for that patient. So you need to talk about options of assisted nutrition hydration with or without oral feeds. You need to talk about full oral feeding and the associated risk of that. And at any point, next of kin or LPA holders can disagree with your decision or your recommendation to eat and drink associated risk. That may well be a point again at which you would talk to somebody about instigating a best interests meeting and safeguarding, talking to your safeguarding team, probably hopefully as a last resort. I typically have found that best interests meetings have resolved any confusion or any concerns that family members have had. It's rare that it would have to go towards a safeguarding meeting. So in this case, looking at some of the outcomes, the husband, so he is next of kin, but he doesn't have a health LPA, but he does agree with my opinion that the patient is not for assisted nutrition hydration. But as part of the discussion that we had, which was a discussion that was had there and then, so I made the decision to have that discussion on the spot there. So I did then learn that there are 3 adult children also in this family. There isn't an LPA for health in this situation, so we need to consider the GP with their duty of care, and my feeling was the best practice was to consult with the GP as soon as possible. So again, this was something I felt needed to be done on the day. So luckily for me, the husband consented for me to speak to the patient's GP the same day. And I'll talk a little bit in a minute about what the outcome with the GP was. I think I did feel that I'd given a lot of information and maybe opened up quite a big can of worms in this situation. And whilst we had a long and detailed verbal discussion, I was conscious that typically patients and carers won't be taking everything in. So what I agreed to do again was with the family was to send an email summary the same day, and did encourage the husband then that he was welcome to forward that on to children in the family and anybody else that he felt would want to be involved in any decisions. So I did do that the same day. I think if you have busy days, as we all do, and something like this comes up, I think you're going to have to make a call again as to whether other things need to be cancelled. I think it's better to deal with these cases, if you can, all in one go and get everything tied up as soon as possible, rather than having things carried over to the next week or to another day. I think we all like to sleep easy at night, don't we? So I personally feel I would rather look at my workload that day, and if it means I had to cancel another patient because this was a priority to get done, then it may well be that those decisions have to be made as well, but only you can judge that. So as well as sending the email summary on the same day, I did also visit the following week to complete the documentation for eating and drinking with acknowledged risk, which we'll talk about in a second. So I've put a screenshot in here of the risk feeding protocol that I'm currently using within Manchester University Foundation Trust. It is actually one that's come from my colleagues, my acute colleagues who are working at Wythenshawe Hospital. It's, if you remember the one that we showed you earlier on, the webinar from Lewisham and Greenwich, it's got similar foundations to that one. I'd be interested as well to hear at the end of this webinar what documentation people are using, whether there is a standard documentation within your team, within your department, or within your area. I think that's something that's probably quite key for us to discuss within our teams, and if we can just discuss that today, that would be great. It's fairly straightforward. It takes a little bit of confidence and getting used to saying some of the things on here. So obviously some of the things it's talking about aspiration pneumonia, malnutrition, dehydration, choking, hospital readmission and death ultimately. So you have to cover those. So you have to be a bit brave, and I think different patients and different carers will want to present it in a different way, and it's really hard. There's never going to be an ideal way to be discussing this, but I think just try and do the best you can. I have recently had a patient I had to do this Misfeeding protocol with again, and there was another family member present, and as I left, they said, "Oh, sorry, we had to talk about that." They actually did say, "No, I'm glad you did. It needed to be said, and you did it in a way that we wouldn't have wanted you to do it in a way that was any different." So I think be brave, and talk to colleagues about how they've approached asking some of the questions or raising some of the topics on this sort of documentation. So if you remember, in the case that I've just discussed, I had made the decision that I felt it was important to speak to the GP as soon as possible, and ideally I wanted that to be on the same day. Luckily for me, that did actually happen. So I did actually get through to the patient's GP within an hour. So I went back to my office and decided that I was going to stay there until I got hold of this GP or somebody from the GP practice. That happened quite quickly, luckily for me. GP was really useful. They were completely in agreement with my decision. They completely agreed that we did not want to go down the path of assisted nutritional hydration. And so interesting for me, then we had a discussion with the GP about the gold standards framework. So I've just put the website address in for gold standards framework and a little bit about it, because I knew a bit about it, but I wasn't completely, I've never seen it in working practice. So it's a framework for end of life care, and they've got their mission statement is to deliver training and support that brings about individual and organisational transformation, enabling gold standard of care for people near the end of life. So it's nothing that anybody would disagree with. From speaking to the GP, I think what it enables, for me, having said that the patient is eating and drinking with associated risk is likely to develop an aspiration pneumonia, what it enables the GPs to do to identify them as a gold patient. And then if any patient requests come through, they are seen as a priority. And the GPs are able to do that. There's no questions asked. The gold patients basically get seen as priority within their very busy caseloads. So that was really useful for me to have that discussion with the GP and understand a little bit more about that. It may be that some of the patients you're working with are already a gold patient. So that's useful to see if you can find out that information. In this situation, the GP visited 48 hours later. I was conscious of, whilst I'm happy to discuss and document eating and drinking with associated risk, I am not the person really to be discussing limitation of treatment, escalation of care and hospital admissions. That is the GP's experience, that's their role, and certainly in this case the GP was very happy to do that and did that, like I say, within 48 hours of my assessment. We were presented with a patient without capacity, then we're following the principles of An act done or decision made under this Act, as is the Mental Capacity Act, for or on behalf of a person and made in their best interests. So I don't think any of us would disagree with any of these principles. And I guess just to finish the story off for this case, so we can see how the patient was admitted in March with a lower respiratory tract infection, which was actually then an aspiration pneumonia, whilst the family wanted hospital admission and treatment with antibiotics and IV fluids. They did continue to orally feed the patient. She stayed in hospital and she passed away peacefully in hospital a week ago. And I did keep in contact with the family over that period of time, and certainly had very positive feedback from them that they felt they were making informed and decisions that they were very comfortable with, and they felt they made the decisions that they wanted to make at that period in time. So our patient is again a community patient who in this instance had a C5 spinal injury a number of years ago in 2016. The patient lives at home but is dependent on carers 4 times a day. She does live with her husband, but recently he has been diagnosed with dementia, so he also has carers coming in. So they do manage to maintain themselves in their own house at the moment. There are recent concerns with this patient regarding primarily her nutritional status. So again, we've got a compromised BMI. Given that in combination with her spinal injury, meaning that she is quite frequently bedbound, then there were significant concerns regarding his skin integrity and wound care. Most recently, in January 2022, were some new concerns in this case regarding some emerging confusion and cognitive difficulties, so problems with memory and recall. They hadn't been a feature of this patient until January of this year. At this point, it was requested for a speech and language therapy assessment regarding swallow. The carers who were the only people who are feeding this patient were reporting choking with solids, choking with tablets. This isn't uncommon, is it, for us to hear that people are choking? So whilst it can sound very concerning, I think sometimes it is a feature of other behaviours such as gagging or not liking the food, etc. But it obviously needs to be looked at fairly urgently. In this situation, it was difficult to get to see the patient in the first place because they're reliant on carers for feeding them, and the carers have a window of time when they're there, and sometimes it's slightly different day by day. So I actually ended up doing 2 bedside assessments. I managed to see with level 0 fluids, level 1 fluids, and level 6 solids. My main concern initially was risk of airway penetration with her normal fluids. This really was secondary to her reduced cough, which was in line with both her spinal injury and also general frailty and fatigue in line with nutritional compromise and position as well. So at the point at which the initial assessments were done, the patient was completely nursed in bed due to wounds and was unable to be taken out of bed and positioned in a chair, so all oral feeding was done in bed. So we've got concerns around airway penetration with fluids, but also there's effortful oral preparation with solids. And given that this is a patient who we have also got concerns regarding nutritional status and it's reducing, then really we should be looking at what is most efficient and effective way of getting nutrition into a patient. As I've mentioned already, she was reliant on all others for activities of daily living. We actually requested that the capacity assessment focus solely on nutrition and swallowing in this instance. We wanted to be clear that the patient understood if she didn't accept nutritional support, if she didn't accept thickeners, etc., that she understood the consequences of that, because really we had nowhere else to go at this point with trying to help this patient. So the GP did initial capacity assessment at the bedside with the patient, again talking specifically around the area of nutrition and the consequences of poor nutrition for this patient, which did include hospital admission and death. The GP did this twice at our request, and both times felt that the patient did have capacity to make the decision around refusing alternative nutrition and hydration. So we were in a position where, as a community team, seeing the patient, we did still have concerns around her ability to make that informed decision. So she refused to display weight loss, skin breakdown, which then means we're reliant on being cared for in bed, which was concerning me regarding compromising her swallow with fluids. She's refused thickeners, but was taking some level 1 fluids, which were naturally thick, and she continued on her level 6 solids. So we felt like it got to a bit of a standoff at this point, and we didn't know where to go. So the social worker did initiate a safeguarding meeting under the area of self-neglect. So we couldn't have a best interest meeting because the patient was deemed to have capacity. So at this point we had a number of safeguarding MDTs under the umbrella of self-neglect, specifically around nutrition and hydration. Of also to note in this case, obviously the husband has been deemed not to have capacity, so he can't make any decisions on behalf of his wife. The son, who does have the LPA for health and wealth, was also of the opinion that they didn't want to pursue any assisted nutrition and hydration. This is an ongoing situation, and it's not really a particularly case that I can tie up for you today, but what is currently happening is, as a result of our request for a second capacity assessment from the GP, which the GP then deemed that the patient did have capacity, I think that just alerted the GP to maybe thinking they should probably look into this in more detail another way. So the patient was referred to the memory clinic. They had an appointment at the memory clinic a couple of weeks ago, and the verbal feedback we've had so far, we're awaiting formal reports, is that the assessment does indicate some features of dementia and memory difficulties with this patient. So whilst at the moment we are continuing to follow the patient's wishes with regards to not assisting her nutrition and continuing with normal fluids, this situation is an evolving situation. It may change, but we also have to consider that there is a family member, as in her son, who certainly does have capacity, who's got an LPA in place, and our next step may be to look at a best interest meeting with him and then see what the outcome is following that. I would be interested in delving more into community rehab practices around documentation and policies in this area. Another reference I've put in is this one here from 2016, complex feeding decisions. This really looked at interviews with staff who are working with the patients and making decisions around eating and drinking with acknowledged risk. So it was primarily professional healthcare professional staff, although there were some patients and carers as well that were interviewed, and the themes that were brought out around making these decisions were supporting the patients and the family, ensuring good communication, that these are complex patients or the complex decisions, and that your care really should focus on being patient and family centred. I don't think any of those themes are things that we would disagree with, and I think they certainly are themes that we would hope that as teams we are working towards. Just another reference I put in here is a recent article, so from last year, which is regarding aspiration risk and misfeeding. Is actually a response to the Royal College of Physicians guidance, which was published recently. So the response is from a group of speech and language therapists who work across a variety of disorders and who have great deal of experience. So it does encompass adults with learning difficulties as well. I've just put in there their concluding remarks are that we conclude that this guidance, as in the Royal College of Physicians guidance, regarding misfeeding supports unduly defensive approach to oral intake and should not be adopted as a standard of medical practice. So I would encourage you to read this. It's a fairly accessible article to read, and I think obviously it's not going to answer a lot of questions, but it certainly raises a lot of questions. I think it just demonstrates really that this is still a contentious area within healthcare professionals. There's a lot of issues and wording that is raised in this article around how the College of Physicians would approach what we've talked about today, so eating and drinking with an acknowledged risk. And if we can't marry the approaches between us as therapists and the patient's physician, who ultimately has responsibility and duty of care, then it's going to continue to be a complex area to work within. So yeah, I would encourage you to have a look at this article. As I said, it's quite accessible to read. So just closing off and bringing forward some summary points from today's webinar. And these are things that are my opinion from my previous clinical experience and from my recent change of clinical experience into community setting. These aren't by any means me saying this is how it is. This is just, you know, how I feel given my recent experiences. We know that looking at eating and drinking with acknowledged risks is a complex area, although actually your clinical assessment might be the most straightforward part of the whole process. So the complexity comes from where your clinical assessment takes you. So my experience is that clinical assessment is not the most complex part of this. As we've seen from some of the articles, and I don't know whether this reflects people's working practices, there is still lack of consensus within, if you're working at NHS, you're working with different healthcare providers regarding what is risk feeding, if we want to call it that, what is the implications of ongoing aspiration, and what is the relationship between a swallow aspiration and resulting pneumonia. However, I feel personally that within speech and language therapy as a profession, and certainly within the therapists I work with personally, that we have a good consensus as a professional group with how we feel we should be managing these patients. I also feel, again, from my personal experience, is that whenever I've worked, for example, with other professionals, so I've put down here dietitians because they're generally the people who are key. You're the key professionals when you're working with patients who fall into this category, that there also is good consensus between speech therapists and other professionals, i.e. dietitians, but I put a question mark there just because maybe that's not everybody's experience, and you know, that's maybe a discussion we can have if people feel comfortable, but my experience is that there's good consensus. Some patients will lend themselves to this being a smoother process, and I guess this comes because of capacity. So I put down there, for example, motor neuron disease patients. So obviously these are a group of patients who will retain capacity throughout their disease. They generally have a clear idea, I think, because of the prognosis with that disease. They have a clear idea about timescales and about their decision making, and I think it's looking at those escalation of care and limitation of treatment decisions is part of their journey from the very beginning. So my experience is that it's a fairly smooth process. I think when we get to the stage where, as clinicians, we're concerned about swallowing ability of the patients, actually by that stage the patients they've already come to their decision that they generally want to carry on with either full oral nutrition or certainly with some form of oral nutrition at that stage. That has been a smoother process in my experience, and obviously they retain capacity, so they are able to sign or demonstrate capacity for that decision. I think it's harder when there is a carer or a relative who feels they've got to make that decision on a patient's behalf, so that is where more support is needed. I think we should be exploring what are the benefits of standard documentation within our teams. I personally would err away from having some very standardised formulaic documentation. I think it can be a difficult and emotional conversation to have with patients and their carers. So it would, I feel, be sad if we came up with a very robotic or very tick box form that maybe people have to present to their patients. I think if we can talk within our teams about how standard documentation we want to use, what do we want to use, different clinicians will have different approaches to discussing this with patients, so it needs to be something that's flexible and that can accommodate different clinicians' approaches. I think from my experiences recently is that I was very conscious about how I was communicating my decisions as a community therapist into the acute services. So as I say, I've been at the other side, I've been the acute therapist seeing a patient thinking, well, why is this patient still feeding orally when they plainly have significant dysphagia? But now as a community therapist, I see how despite your best efforts, it's difficult to get that information to the therapist who is at the bedside of the patient who's now in hospital. So I think it'd be really useful if we could have some discussion around how we communicate these decisions. I think we are obviously limited by our IT systems and our EPR systems, but hopefully it's something that will improve. We can only do the best we can, I think, at this stage, but I'd be interested to know if anybody has any systems that has worked consistently for them. And I guess what I would say from my experiences is that when it works well, which I mean when you have a really honest and thoughtful discussion with a patient and their family, and you're all agreeing and you've all got this, you're all of the same opinion, and yes, we have to do some paperwork, but when it works well, it is a privilege to go through that journey with the patient and with their family. And the feedback I've had from families in this situation is that they really appreciate those discussions. So yes, it does, when it works well, it is very rewarding to be part of. So that's all for me for now. So thank you for listening, everybody. I hope that you found the information useful. Hopefully it will provoke some questions and some discussion. We've got a little bit of time now after the webinar for questions and discussion, so I will hand over to the network team and hopefully I will be able to speak to you shortly and we can have a good chat. Thank you very much.
Hello everybody. Thank you very much for Rebecca for coming on and doing the webinar for us today. Now we'll be taking some questions, so please post any questions that you do have in the question Q&A box and we can post them up for Rebecca to have a chance to answer for you. So we do have a question that's come through, Rebecca. The first one's asking if do you have an aphasia friendly resource that you can use to support capacity assessments, and if so, can you share this?
Yes, I think what I found useful, it's been around for about the last 6 or 7 years. It's actually an ebook. I think it's still, it was only available via Apple Books. So it's called Talk About Aspiration. It's by Catherine Can. Actually, I'll put it up in the chat. It's at the moment it's $7.49, I think, around about that price. So it's an ebook that you download. Obviously, you can only download it onto an Apple product at the moment, is my understanding. But it's an interactive guide. Talks about what is aspiration, what are the implications of aspiration, and leads your patient towards hopefully making as an informed decision as they are capable of making. But I'll put that information up in the chat box. That's probably the best thing to do. Don't know if anybody else has used that resource who's on the chat at the moment.
That's great. And we've got another question, just to say, you mentioned that you had you mentioned that EDR can be changed or rescinded. In your experience, does that ever happen?
I think probably what happens is the patients fall into 2 categories. So you have the patients who have capacity and retain capacity. So they would probably be typically your MND patients. So these are a group of patients who probably, because of this diagnosis, will have had discussions with their family about how they wish their care to proceed. And as part of that, they will have talked about feeding and swallowing. And I think it's easier for the family because they know the patient's wishes and there have been very clear discussions. They typically don't change their minds, or they don't rescind any risk feeding decisions. I think what's more difficult is the carers are acting on behalf of a patient who doesn't have capacity. And I think a lot of these families don't seem to have had those discussions, which why would you? I think why it's not something that you typically sit down and discuss with your family members. So they haven't had a discussion while the patient did have capacity regarding their wishes. So they then feel that they are in a position they are making very important decisions which are going to impact on the patient's health and well-being. And they sometimes in the moment when you're there supporting with that decision, they can see that it's in the best interest maybe to carry on with some degree of eating. But I think when the moment comes and the patient is becoming ill, I think they quite often change their mind, is my experience. I don't know whether other people feel differently, but my experience is that carers acting on behalf of a patient will probably change their minds when they're in a position where the patient is becoming ill and they're looking at hospital admissions, yes or no, tube support, hydration support. I think those are the ones where they probably do rescind any decisions that they have made, which is absolutely fine as well. I can understand why they do that.
That's great, thank you, Rebecca. Another question that's come through is, do you just discuss LPA status with clients, carers in anticipation for of dysphagia within disease progression, like MND?
I think I don't know how much experience people on the chat have had about with LPAs. It's not a new thing. They've been around, but they were called enduring power of attorney until recently. So I do explore tentatively with the family. I don't think you go walk in the front door on your first visit and say, right, who's got an LPA? That would not be the way. I think as speech and language therapists, we're all specialists in communication and working with people, so I'm sure we would all be able to have a discreet discussion and a sympathetic discussion around who has LPA for health within that family if we are anticipating that decisions need to be made. So yes, I personally would, because I think it's in the best interest of the patients to understand what those dynamics are and what the decision-making involvement is within the family. And I think, like we talked about in one of the case studies, thinking about children, if they're adult children within the family, as there probably will be, and how involved they are in their parents' care and in discussions. So I think yes, you should do that, but and we would all be able to do that in a sensitive manner, I'm sure. And LPA is a slightly can be a complicated area to delve into, because you can have an LPA that comes into effect when the patient no longer has capacity, or you can have an LPA that has immediate effect. So there's also maybe some questions you need to ask around that as well. But yeah, certainly ask about it in a sympathetic way.
Thank you. And I don't know, Rebecca, if you're happy to answer this question. It's coming in. The question is about refeeding syndrome from Momina. Are you happy to take a question now?
I have no skills in that area, so I would be absolutely handing that question over to my more qualified dietitians to deal with. No, sorry. It looked like a very, very good question though, but no, I have no skills to answer that question.
Okay, not a problem. So I think we've not got any other questions. So if everybody, thank you for listening to our live today and coming on for the webinar. It's been very informative. Thank you so much, and we hope that it's you know, incited some discussions within your own teams. And if you could, and we thank Rebecca for all her time on the presentation. Thank you so much for you know, presenting our webinar today and taking the questions. The webinar will be uploaded to YouTube and it will be sent out to everybody that's attended. If you could please leave some feedback for us today, just with a number 1 to 5, saying 1 if it needs improvement and 5 if it's excellent, and any comments on any future topics or any areas that you think that you need more training on, then please either email myself or pop something in the Q&A session, and we'll take that forward for you. But thank you very much for listening today. Thank you.